Next is Dr. Priyamvada Yadav from Rohtak. Myriad mechanisms, presentation and our role in pediatric ocular trauma. Dr. Bhatwani, please stay till the session ends.
Pleasant morning. So I'll be talking about the myriad mechanisms, presentations of pediatric ocular trauma and our role to save their sight. So pediatric ocular trauma is quite common in developing countries where children from both rural and urban areas are affected by myriad mechanisms both at home and outdoors. So I'm presenting few cases of pediatric patients under 15 years of age who presented to a tertiary care center, suffered ocular trauma either at home or outdoors by a variety of objects, which were mainly penetrating globe injuries with some extraocular injuries as well. So we are describing the profile in terms of the mechanism and the injuring object, the time of presentation following trauma, the management, and the final visual outcome and sequelae. So case number 1 is of an 8-year kid who got injured with seizures at home while playing, while his parents were out for daily wages work. The child was brought 6 hours following the injury. So we found a corneal tear with multiple flaps, as you can see, along with presence of a traumatic cataract. So after the fitness, tear repair was done. So this was around 12 hours. So 6 weeks later, cataract extraction was done with a sulcus fixated IOL implantation. At 3 months, the BCVA in the affected eye was 618 with a normal intraocular pressure. The child is currently on amblyopia therapy. Next is a case of an 11-year boy from rural area who got injured accidentally by a wooden stick used as arrow while he was passing by. There was a corneal tear with fibrin and traumatic cataract. The child was brought 6 hours after the injury. Tear repair was done along with intravitreal antibiotic injection after 6 hours following fitness. And the eye was followed till it became quiet. Cataract surgery was done after the eye became quiet after around 2 months, and the best corrected vision in this eye was around 6/6 part at 3 months with a normal intraocular pressure. Then an 11-year boy who got injured by a flying hockey stick while he was passing by. He was brought 3 hours following the trauma. There were multiple orbital valve fractures with a canalicular tear, upper and lower lid marginal tears with conjunctival tear and traumatic mydriasis. So we did an exploration and repair after 8 hours. The child had quite good cosmetic results, 2-month post-repair, and the BCVA at 3 months was 6/6 part with a normal intraocular pressure. This was an 8-year girl. Actually, we have seen a similar kind of patient in one of the previous presentations. So there was a history of trauma by vegetative matter, JOAR, in this case, 3 days back before the child presented. So, and the child was using already some eye drops given from some local practitioner. The vision at presentation was 618. So on examination, there was an intracorneal foreign body with presence of anterior chamber reaction, a pharmacologically dilated pupil, and good fundal glow. So we removed the foreign body and the tear was repaired. The vision was 6/6 with correction following suture removal with some astigmatism at 1 month. At 3 months, this was good with the normal intraocular pressure. Then is a case of an 8-year boy who got injured by wood while playing, was brought 1 day following the injury. There was a corneal tear with sphincter tear and traumatic cataract with a vision of counting finger 1 meter. The repair was done after 6 hours. The traumatic cataract extraction with IOL implantation was done 1 month following this. At 3 months, the BCVA was 618 with astigmatism. Then a 10-year boy who was brought to us 5 days following trauma by iron rod while playing outdoors. He had a corneoscleral tear. This was actually time because the tear could not be seen, maybe because of the circumstances or ignored or neglected. So there was a corneoscleral tear with fibrin post-op day 1. After repair, we found a shallow anterior chamber. We did a pad patch for this patient. Post-operatively, 1.5 months, the child was doing good. At 3 months also, the vision and ocular pressure were fine. Then a 6-year boy injured by wooden stick while playing when his stepmother was not around. There was a corneoscleral tear with a traumatic cataract. a 12 years girl from a rural area of another state. She was brought 3 weeks following trauma by a branch. In this time, she was given treatment by some local practitioner for 2 weeks. Then the child was referred, and after referral, she came to us 1 week. 1 week after the referral. So at presentation, this was the picture, vision of hand movement. There was a sealed corneal tear with whole anterior chamber full of lens matter. Now this is something that is not acceptable. We can see grossly what is there in the eye. So this has not to be missed. There was an intraocular pressure of 32 by non-contact tonometry, and there was a cataractus lens on ultrasonography. So we did a tear repair with anterior chamber wash. After 2 weeks, when the eye was quiet, an IOL implantation was done. At 1 month, the corrected vision was 618 with normal fundus. At 3 months, she had the best corrected vision of 69. So the child is on regular follow-up for intraocular pressure along with a regular disc examination, because she has been under that much high intraocular pressure for quite long. Next is the case of a 13-year boy who fell accidentally stumbling over a bench at home. The child was brought within 1 hour of injury. There was a limbocorneal tear with uveal prolapse, and it was repaired after 4 hours following the fitness. At 3 months, the vision was good with a good intraocular pressure. And the last case is of a 5-year girl who got injured with pencil while fighting with the sibling at home. The child was brought 4 hours after the injury. There was a corneal tear with uveal prolapse. Repair was done 6 hours following the fitness. At 1 week post-op, she had a vision of 624 part with a normal fundus at 2 weeks. The best corrected vision at 3 months was 612 part with a normal intraocular pressure, and she is currently on amblyopia therapy. The conclusion here is that pediatric ocular trauma is common, can occur by myriad of mechanisms and objects. A thorough examination, timely and optimum management, and if we find it out of our scope, the patient has to be referred timely to save the useful vision and quality of life of the patient. Protective and preventive measures to prevent the mishaps leading to ocular injuries, their importance cannot be underemphasized. So awareness regarding different mechanisms of trauma, prevention by following appropriate measures, particularly the prevention, now protection of the other eye. Once the child has suffered injury in one eye, that again becomes very important. Timely presentation to a healthcare facility with optimum management. Preserve the vision and quality of life of children. This is very important to reduce the social and economical burden on the family and the society. So I'm thankful to all the patients who entrusted us with their treatment, and the residents of PGIMS Rohtak, Haryana, who left no stone unturned for the fitness of these patients for their timely management.